as Kathleen said, for our InProcess presentation. I'm Lauren Haldeman, and I'm a faculty member in the Department of Nutrition at UNCG. And I have with me two of my PhD students, Coleman Murray and Tina Ear, to present some of their research that fits very well with the goals of LEAP, which is our Lifetime Eating and Physical Activity Practices collaborative that began about 4 years ago. And it's a collaborative that has a leadership team and then a core team that's an expanded group of individuals who helps to guide our initiatives around eating and physical activity. So our leadership team consists of faculty from North Carolina A&T, Joni Chavis and Karen Jackson, as well as Kathleen Edwards, who is our host tonight, myself and Emily Yankee from the Institute of Community and Economic Engagement and Peace and Conflict Studies at UNCG, as well as our core team who have been invaluable in the work that we've been doing, Michelle Gill-Moffitt, Michael Hempel, Jay Cochran, and Marianne LaGreco. So LEAP started, like I said, about 4 years ago, and our goal, really broadly speaking, is to improve health and working towards a greater understanding of eating and physical activity practices in Guilford County. It's a big job. But we've been working on it. We've been working at it long and hard, and we really want to create that space to improve health, to encourage community, and also to bring together community and academic partnerships to be able to work together to meet the goals of LEAP. We work with data, and we would like to help to improve the data that's available around health, again, particularly around eating and physical activity practices in Guilford County, and to really advocate for that. So ultimately down the road, that we're seeing policies around improving overall health through this mechanism of eating and physical activity. You'll see on the bottom of this, it's a hyperlink, and you won't be able to access it right now, but it is accessible on the LEAP website, which is our progress report. It's what we have been doing and working towards for the past several years with LEAP. So it's a good read if you get a chance to take a look at it, so you can see what it is that we've been focusing on. So it's a little bit about LEAP and how we started and who's involved with that. Now I'm going to get to really the central part of this presentation. And when I was really thinking about how to bridge together the work that we're doing, that Coleman's doing, that Tina's doing around health, and particularly child health, that's really where our focus is right now, and eating and physical activities. The first thing that came to mind was community, right? So community, that it takes a community. It takes a community for people to be healthy. A community serves as a promoter of, an impediment to health. And a community consists of its people, its structure, its resources. But it's also important that a community is aware of what's working and where do we need to improve on. So the work that we're going to present today addresses some of these things, what's working and where do we need to improve upon. The other thing that I really thought about was this continuum of health. How, where, when are we learning healthy behaviors? Where are we getting that foundational information, and how does that then translate into health? And then how do we manage that? How are we managing health? Who's helping us along in that process of managing our behaviors so that we can promote good health? And while this is a little skeletal, and it certainly doesn't encompass everything, what I wanted to show was this idea, and again, it's connecting as it relates to eating and physical activity, it's connecting the work that Tina and Coleman are doing currently right now, but really looking at what's happening in the home to promote health or to learn about health, or to become familiar with healthy eating behaviors. How do parental feeding practices impact that health? How does parental modeling impact health? So for instance, how are our parents and caregivers, what are their eating behaviors look like? How are they modeling healthy eating behaviors? How are parents and caregivers modeling physical activity, being physically, getting out and being physical and getting out, moving, and how those types of things, how those practices, those behaviors, those values translate into building behaviors in the home. And how do they then translate into child health? Where this continuum kind of connects everything together is, okay, so we've built behaviors. Children are learning about healthy behaviors and healthy practices, but we don't always do what we're supposed to do, right? We tend to have health outcomes that aren't necessarily ideal. However that translates, whether it's translating into unhealthy weights, whether it's translating into diet-related chronic disease. So how do we manage that? And the messaging that we get, we rely on our medical providers to be able to message to us and to provide us with recommendations like eat healthy foods, right? Avoid fast food as much as possible. Eat healthy snacks, fruits and vegetables. Avoid sugar-sweetened beverage overconsumption. So these are the types of messages. Be physically active. Get out there and move. Work your heart, work your muscles, work your bones, and to get regular checkups. And these all seem very straightforward. Let's eat healthy foods, be active, and get regular checkups. What's critical to understanding is how do we put these recommendations into practice? And what are our barriers to being able to do this? And we know, if you've not heard of social determinants of health, it's what affects where we live, where we play, where we work, and how do these social determinants of health impact our behaviors at home, our behaviors or the recommendations that we're receiving from medical providers. Households that are food insecure, they don't have access to healthy foods. Which makes it more difficult to be able to carry out those recommendations. Education, knowledge about healthy eating, about physical activity. So having levels of education that or levels of knowledge that don't include this type of information. Living in geographic areas where healthy food options are not possible. Food deserts, where it takes, it's a very long time to be able to get to a grocery store that has healthy food options, or food swamps. If you're not familiar with food swamps, it's living in a geographic area where the only food outlets around you are fast food outlets. Health access, so regular checkups make sense, but if you don't have ready access, or you're not able to get to a regular medical appointment, whether a wellness check or a sickness check, these all impact those behaviors and these recommendations. And lastly, unsafe neighborhoods. So it's one thing to say be physically active, but if you can't go outside, it's not safe for you to do that. It makes having those recommendations very difficult to follow. And again, particularly, I've highlighted only a few. This is not exhaustive, but certainly as it relates to these two projects that we're working on to really better understand what's going on in the house and what types of recommendations are we receiving from medical providers who are there to help promote that good health. So as I mentioned in the beginning, we've got Coleman and Tina here, and they'll each be talking about an individual project. I'm not going to go into much detail, but just generally speaking, Tina's project is to better understand what's going on in the home around eating behaviors, if and how healthy eating is being modeled in the household and who's modeling it. And Coleman's going to talk a little bit about how medical providers are, or if they are, tailoring their messages around chronic disease prevention, and how those messages may or may not integrate social determinants of health in the treatment of patients. So I'm going to let them talk more specifically about what's happening. We are in the initial stages of these, so this will give you a little bit of an idea of the research that's currently going on. And then in the end, we'll have some time to talk a little bit about, well, what does all of this mean? Where do we see the next steps for this? And then I sure hope we'll have some time at the end as well to get some questions from you and some input about the work that's going on. So I'm going to turn this over to Tina to start us off.
Great, thank you, Dr. Haldeman. Hi, everyone. My name is Tina. Very nice to meet you. So this is the official title of my dissertation research. And you see here that we're talking about fathers. This is, of course, in a family context. But as I'll share with you, we really have a gap in our understanding of the impact that fathers have on the eating and feeding environment in the home. So first, let's get grounded in childhood overweight and obesity. These statistics are likely not new to any of you, but I think what's important to think about, in particular about the 1 in 3 children that are overweight or obese, is consider that 22% of those children are, the racial profile is 22% Black and 26% Hispanic. So when you think about in totality, in terms of social determinants of health, you start to see how we need to be aware and cognizant of making sure that when we're doing this types of research, that we are truly evaluating the impacts at not just the household level, but taking into context, how does this apply to different families? So mainly what we will look at, and this is from the father's point of view, is we're going to look at what is the father's influence on the child's weight status, or what is that association with weight status. And when you think about parenting and just impact on child weight status in general, we know that the family and moreover parents definitely have an impact on lifestyle behaviors. And this is anything from diet, and as we've talked about, I know you all focus on quite a bit, physical activity, and other things like screen time. So how much screen time is the child spending per day? And we know right now with COVID, that's all over the map for obvious reasons. But also, the parents set the pattern for the child, even with relationship to sleep patterns. So thinking about the family, and in this case, our fathers, what are their impacts on these lifestyle behaviors? And these have lasting impacts on children as they enter into adulthood. So in this picture, what we see here, it's a kind of a parody. We see the father, he's in the upper left, he's trying to manage, taking the child out for the walk and maybe reading to the child and feeding the child. And on the bottom right, we see mom going out the door. So we know that in recent decades, this is truly happening with a lot of our families. And we see a lot of fathers taking on roles and responsibilities that they may not have been prepared to take on or socialized to take on. But we know the shift is happening. And so you might be asking, well, what is really driving this shift? And we're interested in that. So we have some slides to share with you about that. So the first thing, and probably the most obvious, is maternal employment. And if you think about in the last 40, 50 years, we've seen significant shifts in maternal employment. And when you think about, gosh, the last year, yeah, I think it's also critical to think about, and we'll capture this in our research, what has been the impact of both parents having to pivot and work from home. So now I think in a way, and Dr. Haldeman, and we've all talked about this, in a way, for my research at least, COVID is kind of a gift horse in the mouth, because we have a lot of dads all of a sudden finding themselves in the position of being home all the time, and participating in more and more of the behaviors and requirements to parent, and especially food parent at home. So we know we have increased in maternal employment, which then leads to these shifting roles in the household. And we are seeing significant increases in fathers participating in food shopping. And if you think about the past year, if mom or dad were going out to go to work, they might be the one that were stopping at the grocery store. And so that fell to whoever was doing that. We also see that fathers are more and more participating in meal planning. And that's not just the food shopping, but actually thinking about, in the span of a day, how am I going to plan the meals for the children, breakfast, lunch, dinner, snacks, participating in meal preparation, and really important, participating in portion, helping the child decide what portions to have on their plate. I really like this graphic as well, because I think it really helps put into context how much time are we seeing fathers spending on housework and child care activities. And since from 1965 to 2016, as we see here, we've seen a significant increase in housework from 4 hours a week to 10 hours a week, and childcare from 2.5 to 8 hours per week. And I would bet you there are a lot of dads who are spending a lot more time on these activities, especially in the last year, simply because they've been at home more often than they might have been. So when we think about this shift, it's starting to be referenced as the new fatherhood in the literature. And, you know, as this shows, I'll just say, I mean, we've literally seen over 50 years, these activities double, that fathers' participation is actually doubling. So there was a 2013 report that came out, and apologize, I'm going to make sure I get this right, from the National Center for Health Statistics, that looked at fathers' involvement in child feeding. And they were able to get a nationally representative sample of dads, and they found that more than 60% of these fathers said that they were feeding, this is important, not just sharing, but they were feeding. They were actually in charge of feeding the child a meal at least one time or more per week, per day. And so again, I'm sorry to keep bringing up COVID, but we know in the past year that has likely increased many times over for some households. And so another statistic that's important to think about is we are definitely seeing an increase in the number of fathers who choose to stay at home. It's not a decision to be at home and now they have this stay at home because their job is at home, but they are preferentially choosing to stay at home to participate and be a stay-at-home dad. And we've seen in the last 20, 30 years, it's starting to really trickle up, you know, from 89 going from 10%, and now it's at 17% in 2016. I would argue it's probably higher than that by now. We just don't have that data yet. And what I'm talking about is their decision that it is specifically to stay at home to care for the children. 24% of those fathers made that was the main reason they chose to be a stay-at-home father. And we're really also seeing that when we move from Gen X to millennials, we're seeing that trip up even more. And I lose track of what generation that we're in now. Is it Gen Y? I would argue, I think if we look at the Pew Research, and this comes from Pew Research, I would bet that we're seeing it go up even more with the Gen Y fathers. So when you talk to fathers, this research that these statistics are represented in are from a 2012 study. And this study looked at what fathers perceived to be their responsibility. 71% perceived that they should share equal responsibility. 50% felt that they should be participating in selecting food and portion sizings at least half the time. So you figure in a traditional family structure, dads that work away from home might be at home for 2 meals. So, and maybe not even, they might be away for 2 of the 3 meals. So breakfast and lunch, they might be out of the home. So they're saying that 50% of the time I should probably participate in making food and portion decisions for my child at dinner time. That's the way we interpreted that. And then 26% said that they want to increase their participation. And I think that is really speaks to, those statistics that we were looking at the slide before, when we look at the differences between Gen X and Gen Y and millennials. Well, I didn't have Gen Y on there, but when we look at Gen X and millennials, that is not really a surprising statistic at all. We see typically with younger dads, 20s, 30s, even 40s, there's definitely interest to participate in feeding. And then we know that fathers, so you might say to yourself, well, why is it so important to look at dads? Well, part of the reason, aside from all the things we've already talked about, is that there's been research that has definitely indicated that fathers, the way that they food parent, it is different and above and beyond the contributions of those contributions made by the mother. So they're unique and different. And I think if you were to think about your own households, if you have children, and we were all children, we know that we responded typically differently to our moms than our dads in a lot of cases. And so there's that difference in relationship that has that impact. It's also a different, just a different parenting relationship in a lot of families. So we know that thinking about fathers, especially as it relates to obesity prevention and family-based interventions, we definitely need to incorporate how fathers are impacting these behaviors that are unique and different than moms. So when all of these things are brought together, where we end up is with this white space in the middle. We have a gap. We definitely have a gap in the literature, in our understanding of how fathers are contributing to parenting, food parenting in the household, and how do we support that going forward. So, as you might have imagined, some of the things that we will focus on, and are focusing on, I should say, we've developed for our first phase of the research, which has started about 3.5 weeks ago, where we are asking fathers in a survey to talk to us a little bit, give us some indications about their food parenting styles, their food parenting behaviors. We'll have a second phase of our study, which will ask fathers about their diet quality. We'll ask them to complete some diet assessments so that we can kind of gauge where dad's diet quality is. And then we'll also have questions on the first part of the survey that will ask about nutrition knowledge, because we're interested to know what do fathers know about general nutrition concepts. And then in the third phase, we'll take all of that information and we'll ask them, given what we now hope to better understand, what would be the best way to help them increase their knowledge and their self-efficacy. So first, let me ground you in parenting styles. So when we talk about parenting styles, there's, think about a grid, and I have a picture for you on the next slide. Maybe we should just go to that. So when we talk about high demandingness on the y-axis, and then we have responsiveness on.
Hold on.
And then we have responsiveness on the x-axis. So as we see, so demandingness, think about during meal time, demandedness describes the degree of persistence on the part of the parent to encourage certain behaviors from the child. So, such as having the child insisting that they finish what's on their plate is an example of that. And when we think about responsiveness really is, it measures the parents' how sensitive are they to the child's needs. So if the child says, oh, I'm full, does the parent actually acknowledge that? So when we think about either high demandingness or high responsiveness, we end up with authoritative. And that the authoritative parenting style, the research suggests this is the most supportive for helping children develop more balanced eating behaviors. It encourages their autonomy, and it also recognizes their needs. It's also really important in the authoritative versus authoritarian. For example, authoritative parents will typically explain why they have a certain rule, if you will, versus an authoritarian style will be more likely to impress upon the child that they must do it because that's, do what I say, do what I've asked you to do. So there's food styles and food parenting styles and food parenting practices. So the styles we just talked about in terms of demandingness, responsiveness, food parenting practices really get at those behaviors. And the three behaviors, there are many, many behaviors, but we'll be focusing primarily on utilization of coercion, autonomy, and structure. And it's important to understand that when it comes to behaviors, these include behaviors that are both intentional and unintentional on the part of the parent. So when we think about coercion, think about things that are more parent-centered and, the child is being pressured to finish what's on their plate, for example, maybe using threats and bribes, or, if you finish half of what's on your plate, then I'll let you go do XYZ, for example. And we've all done that. We've all been there. And then there's also the use of food to control negative emotions. So we see this oftentimes with younger children. If they have a temper tantrum, we might offer the child a treat to get them to calm down. So those are some examples of coercion. When we think about promotion of child autonomy, it's, offering those choices, letting the child decide when they're full, for example. Helping them, when we talk about fostering nutrition education for children, getting them familiar with different fruits and vegetables, for example. When they go to the grocery store, letting them select foods that might be prepared at home and get them to try something new. And then, and that goes along with getting them to participate in meal planning. And then structure is a really important food parenting practice. And this is, setting those rules and limits, using more guided choices to, again, promote that child autonomy, monitoring what they are eating, making sure that you're aware of the snacks that they're having, for example, making sure that there are routines around mealtime, and modeling. Modeling is so important. Children will often take their cues from parents as to what they might eat or not eat, for that matter. And then making sure that healthy snacks are available and accessible to the child as age appropriate. So the bowl of fruit on the kitchen counter, or having snacks cut up in the refrigerator that's easy for them to grab. All right, so I've talked a lot about all of the pieces and parts and of why we have talked about the research. I've talked a little bit already about that there is a gap. And I just want to point out the statistic at the bottom of the slide, and that is that in a systematic review in 2016, there were 600 studies that looked at the topic of obesity prevention with families, but only out of that 600, only 17% included fathers. So there is a lot of room for adding to the literature. And so, as I mentioned, we have developed a 3-phased approach to our research. We will have, if you see, we'll have the father surveys. We have our upper left, right and left quadrants with our 2 dads helping their children with meals. That comes to the middle with our online survey. On upper left, we're going to use the NIH, National Cancer Institute online dietary survey assessment tool for the 2nd phase. And in the bottom right, we will have virtual focus groups, which we think will occur later this summer. So we have 3 specific aims, and I won't read these out to you, but as you might imagine, we are looking specifically at food parenting practices and styles. And also, we're going to look at the interactive effect of their healthy eating. So looking at that dietary assessment and knowledge, and how is that associated with child weight status. And lastly, as I talked about with the focus groups, we'll also be interested to find out what are their interests in terms of nutrition education, and what are the modes that are preferable for them. Is it online, or is it face-to-face, for example? And so last, a couple of things that, this is significant in that we believe will add some value to increasing the efficacy of family-based obesity prevention programs for children. It's really important to include our dads. And we are, so far, what the data is showing us is we're getting good diversity. It's important. A lot of the father research to date is mostly white fathers. I'm really happy to say that we're getting a really good representation of Black and Hispanic fathers as part of our current the 1st phase. And then innovation, we are using a novel recruitment strategy. We've partnered with Cone Health. That survey, as I said, launched about 3.5 weeks ago. That's going out to all 6 of their sites, their hospital sites. And COVID kind of threw a monkey wrench in our partnerships with these other organizations, Cooperative Extension, but we are in the process of making that connection and hopefully reaching out to some of our dads through the 4-H organization. So I've talked probably a little bit too long about how our household behaviors impact our interests for supporting families. And now we're going to switch gears, and Coleman's going to talk about her research that focuses on that healthcare messaging and taking into consideration those social determinants of health.
Thank you, Tina. So here is my fancy dissertation title. I'm Coleman Murray, and I'm really focusing on the medical provider's role in, supporting an adolescent's healthy life. So my focus is specifically on adolescent hypertension and how medical providers are, how and if they're using social determinants of health in their messaging. So we're going to keep going for sake of time and just jump right in. So our prevalence of adolescent hypertension is around 3%, with another 3% of youth having elevated blood pressure. And we know that there's a higher prevalence in those adolescents in that overweight and obese BMI categories. This is, of course, concerning because we know that elevated blood pressure and hypertension can lead to increased target organ damage. It also accelerates that vascular aging, and it puts them at much greater risk of hypertension, cardiovascular disease, and stroke in adulthood. So looking at the heart.org Life Simple 7 infographic here on the left-hand side, you see that they've identified 7 main risk factors that we really are concerned about and want to make sure that adults are, getting active and eating better and maintaining that healthy weight and controlling their cholesterol, managing their blood pressure, and managing their blood sugar, as well as stopping smoking. But then when we start to look at some of the adolescent research, we see that 85% of adolescents aren't meeting physical activity recommendations. 98% aren't meeting the minimum consumption recommendations for vegetables. 86% of adolescents aren't meeting their minimum consumption recommendations for fruits. Children are consuming 4 times the recommendation for sodium. We've got 10% of high school students reporting that they're smoking cigarettes, and 1 in 5 adolescents falling into the obese category. So, these are super concerning statistics and really make us, realize that, wow, adult cardiovascular disease doesn't just begin once someone hits adulthood. It's really originating in adolescence. So we have a whole myriad of factors that are influencing adolescent hypertension. So you can look at this graphic and see that we have some psychosocial factors like ethnicity and socioeconomic level. We also know that metabolic influences like diabetes can influence the development of hypertension. Poor diet quality or poor sleep can also influence hypertension, as can overweight or obese status. Also, lack of preventative health care or lack of regular checkups can be a factor that influence hypertension. We've also already discussed those major consequences that can happen, which you see in the red box in the bottom. So that's part of the reason it's so important to have regular screenings in our communities for hypertension to help prevent the onset of these negative consequences. It's also important to think about the fact that some of these things we can change, right? So we can help someone improve their diet quality. We can help someone have better access to health care. But there are some things we can't change. So we can't change someone's ethnicity or their family history of hypertension. We can't change their socioeconomic level. So, despite the fact that we can change things, and interventions also often focus on what we can change, we really also want to think about those populations that belong to those risk factors that we can't modify, because those populations may be the ones in, the most need of that intervention. So a little bit of preliminary research, and just to really simplify it, we're just going to look at these blue bars, which represent healthy weight individuals. And these 3 categories here on the, I'm sorry, I'm moving my mouse and that's probably not moving on your screen. The prehypertension, stage 1 and stage 2, those are abnormal blood pressures. So this is showing us in these blue bars, there's a large amount of healthy weight individuals who are in that abnormal blood pressure range. So for girls, that's actually right at 50% of girls with abnormal blood pressure that had a normal weight status. For boys, this was around 45%. So this is starting to show us that, it's not just those adolescents in that overweight category that are of concern. We do actually have some metabolically obese, normal weight adolescents that we need to be watching for as well. So what did this really tell us? And just to sum it up, we know that excess weight is related to high blood pressure. As we said on the last slide, we now see that even people at a normal weight are also at risk. We also know from that research that our activity and lifestyle behaviors did not adequately explain the rates of hypertension and obesity seen. So there was something else that was potentially causing that. So that led us to social determinants of health as, what else could be causing those rates of hypertension. So Dr. Haldeman introduced us to social determinants of health in her introduction. So just think about real quick, if you have an adolescent that you've worked with in the community and you told them, you know, I want you to eat more fruits and vegetables. And they go home and they think, you know, the parents heard that advice and they think, well, I don't really have the income that supports me purchasing those fruits and vegetables. Or maybe you gave them a pamphlet, a nutrition education pamphlet, and they go home and they read it and they think, well, this didn't really think about, you know, my income level or the fact that I don't live in housing or I don't have the supplies to cook with. So that's where the social determinants of health piece comes in. And we're really curious about how medical providers or are learning about this material from their patients, and then how they're utilizing it in their messaging to adolescents. So this big tangled web puts together all of our risk factors and highlights in yellow those risk factors that are social determinants of health. So some directly influence the risk of adolescent hypertension, while others indirectly influence another known risk factor. So just for one example, food insecurity influences dietary intake, which then influences that risk of adolescent hypertension. Barriers to care. So as if social determinant of health barriers aren't enough, we know our adolescents and families and medical providers all experience a whole host of other barriers. So from lack of insurance to just simply family members thinking that there's no need to change. You know, if someone doesn't think there's a need to change, or if they're not ready to change, it's really hard to support someone through that process. Our medical providers, time's probably the number one thing we hear about. I don't have time to include those lifestyle discussions during the medical appointment, but also we're seeing that there's some lack of comfort reported by physicians in the evaluating of adolescent blood pressure, as well as maybe a lack of knowledge and comfort with making those nutrition recommendations. So number one thing we can do is screen, and that's so important in our community. The research that I showed earlier was actually all collected from this region. So those high rates of hypertension and obesity are right here from our backyard. And so screening is the best thing we can do. Prevention is also super important. So helping people maintain that healthy weight and encourage exercise, both super important. We can't just do one. Research shows us that lifestyle, diet, and exercise are all three components that we really want to integrate into an approach. Tina covered our parental support needs. And then we also want to consider that adolescence developmental stage. You know, they're influenced by what their peers see, and we don't want any bullying to occur. So we don't want to treat someone differently. We want to make sure that those behavior modification interventions are done in a way that would make that adolescent comfortable. And lastly, we want those interventions to be adaptable. So I think from Dr. Haldeman's introduction, you're pretty clear about our aims of the research. So real quick, first thing we're doing is getting medical provider feedback through a survey. So we're recruiting MDs, PAs, and NPs to complete a survey, an electronic survey that has a whole host of questions related to demographics, the medical provider's knowledge of the guidelines, their comfort level, their use of social determinants and messaging, as well as their access to a registered dietitian. So as a quick sample, this is a Likert scale of 1 through 5 based on the medical provider's comfort with diagnosing, treating, providing nutrition recommendations and physical activity recommendations. We've seen some research where some medical providers have shown that they were uncomfortable with this process. So we want to elucidate more information. And then here's a sample question regarding what we're asking about medical providers knowledge of social determinants. So for example, the third one, I have knowledge of the safety of my patient's neighborhood. It's important that you recognize while we collect information on social determinants of health, or I say we, while medical providers collect that information, that could come from a couple different places. So the front desk, maybe they fill out a form in the waiting room. It could come from a nurse. And it could come from maybe the medical provider asking themselves, but we're not quite sure as to, whether or not that physician would have that knowledge at the moment when they sit down to make those recommendations. So the other part of my study is looking at some interviews. So we want to sit down with 15 medical providers for a 15 to 20-minute interview and discuss more in depth some of those topics from the survey. And we've got a couple sample questions here for you. So for example, question 7, how do you approach discussing weight-related or diet-related chronic disease? And then we could use some probes of who do you discuss this with, and what specific weight suggestions, nutrition recommendations, and physical activity recommendations would you be giving to that patient? So this just gives us a little more in-depth idea of, the medical provider's process. So this is definitely significant. World Health Organization cites cardiovascular disease as the #1 cause of death globally, killing almost 18 million people each year. We know hypertension starts in adolescence, or that those risk factors are starting in adolescence. So we want to continue increasing that awareness. We want to continue making sure that our adolescents are screened regularly and that they're not going undiagnosed. We also know healthcare institutions are collecting this social determinant data, but maybe not quite sure what to do with it yet. So just because they've collected it, we want to make sure that that data is being utilized. It can influence our community efforts. It can influence, interventions that we're offering. It can also influence the messaging that our medical providers are offering. So this is definitely significant. It's also innovative. So, on the researchy side, no studies have addressed medical providers' comfort with these new recommendations. We've definitely seen no study addressing medical providers' knowledge of social determinants of health. We've seen research saying, oh, medical practices are collecting this information or this information, but just because they're collecting it, we don't know that physicians know that information. So ours is a bit unique in that we really want to see what medical providers have knowledge of, poke a couple holes in the system and figure out, okay, how can we make sure our medical providers have knowledge of this information? And that's really what this last one's saying is we aim to provide some recommendations. So how can we really include social determinants of health in a full assessment of the adolescent? That is a picture of, a piece of their health history. Those social determinants definitely influence the adolescent's health. And it also allows us to really work to tailor our care to meet each individual adolescent's needs based on those social limitations.
I think that's, here we go. Okay, there we go. That's it. All right. Thank you very much, Tina and Coleman. I didn't put up a next step slide just to avoid slide overload. But I did want to say, our goal in all of this work is really, as both Tina and Coleman pointed out, I like the poke some holes in the system so that we can help out as best as we can. But what we'd really like to do is be able to understand how we, as nutrition professionals, can help to improve or to better understand what's going on in the household and how we can help to improve health, and also to help medical providers know their patients better, to know more about them so that they can best tailor their messages So I know we've hit on a couple of different things here, and there are so many more implications for that, but I did want to leave a little bit of time for questions if you had any. I think we might have about 5-6 minutes or so for questions.